premise of this problem is the amount of water in your body. And the trigger for the negative feedback circle is the amount of water in your body. If it's low, it's going to release the hormone. Okay? Because, don't have to explain it, anti-diuretic, anti-pee, okay? We're going to hold on to it. So, what labs, well, let's look at these. Here's what we're going to talk about, the glands. Here's what your labs are going to look like. I have too much anti-diuretic hormone in SIADH. So, therefore, I have a lot of water. My sodium is going to be low because with all this circulating water, it's dilutionally low, okay? My urine-specific gravity is going to be high because what's my urine going to look like?
Concentrated.
Concentrated, has a lot of sediment particles in it, maybe pretty dark. So that's what my urine is going to look like, and that my urine-specific gravity is going to be high. Here are our causes. Brain tumors, specific lung cancers and infections, TB in particular. Meningitis, because what is meningitis? An infection of what? The meninges in your brain, and what is located right there in the middle of all that?
Pituitary
Your
gland.
pituitary gland, so that's why that's up there. Medications that we use to treat diabetes insipidus can create the opposite problem. So those are our main causes. So, what are our signs and symptoms? If I'm holding on to all this water, what do you think I'm looking like? Edema. Okay, you would think I would have edema, but I don't have edema. I don't have peripheral edema because it's circulatory volume. So, you're going to have hypertension. Where am I going to have my edema at if I have it? In my lungs. You're going to see distended veins, like you're going to see JVD, and if it's too much fluid, you're going to hear it in my lungs. That's where my edema is going to be. So I'm going to have pulmonary edema, not peripheral edema. What else do you think is going on with them?
You gonna have dark urine, like the urine from the dark.
Okay, dark urine, cloudy. What about my weight? Up or down? Up. My weight's increased. Is it water or nutrition?
Water.
So how often do I want to weigh my guy?
Daily.
Every day. What you said about my hypertension. What about my pulse?
Bounding.
Yeah, increase a little bit because I'm just really working hard. And bounding, you're going to be able to see it. You're going to be able to feel it really good. Feel like that? Pulse is creeping around. Pulse is keeping alive. What about GI? What do you think's happening in GI?
Constipated.
GI, not urine. Your belly. GI tract.
Ascites.
You're gonna have, okay, you might have some ascites, but you're not gonna have any interest in eating because you're so full, you just don't feel like eating. So they have a lot of anorexia, but they're not gonna want to eat, but you're still gonna see the weight gain because of the water. Okay. What about neuro? Confusion, possible seizures, level of consciousness changes related to that low sodium level. Okay. Hold on. Why are we going backwards? Okay. What do you think I want to do to take care of this person besides the daily weights?
You're gonna give them diuretics.
Okay, I'm going to give him diuretics. We're going to talk about those in just a minute. So I'm going to give him diuretics.
Iron restriction.
Fluid restriction. I want to restrict their fluid.
Monitor eyes and nose.
Okay, eyes and nose.
You gotta increase sodium. Seizure precaution.
Okay, increase sodium diet. So if I do that, that's a debate because if I say you can have all the sodium you want, what are you going to want to do?
Drink fluid.
You're going to want to drink a lot. So that's debatable. Sodium is the slowest electrolyte to correct itself. It takes the longest to correct your sodium. So yes, you can give them some additional sodium in their diet, but then you still got to be cautious of the water. Right. We don't know what they drink when we're not in the room. I don't know if anybody in here watches Grey's Anatomy, but do you remember the one where the guy had SIDH and they were trying to get him to quit drinking and he's drinking out of the toilet bowl? Because they're so desperate for water or something to drink that they're going to find a way to get it. And we're not with them 24/7. I mean, I can't see you when the door is closed when you're in there by yourself. Do you think this person has any safety concerns?
Yeah.
Okay, fall risk, because why? The decreased LOC and the confusion, they have the fall risk. Elevate the head of the bed, because I already told you, you might have pulmonary edema, and if I can't breathe and I'm laying flat, how's that helping? So elevate the head of the bed. So safety issues, the daily weights we talked about. Oh, and somebody wants to talk about the diuretics. So I'm going to give some Lasix first. What do I need to be thinking about when I'm giving the Lasix? The potassium level. Because their potassium level is not necessarily out of whack other than dilutionally. But as I'm pulling the water off, I'm pulling the sodium and potassium too. So I need to be monitoring the potassium level. Hypertonic IV fluids, such as dextrose would work. Saline's normo, it's isotonic. I want to give hypertonic.
Lactated ringers.
Lactated ringer is isotonic. So that's the same. 3% normal saline. Okay, instead of your 0.9%, 3% normal saline. So how does hypertonic IV fluids work? It draws the fluid into the vascular system and hopefully you get rid of it in your urine. Okay? So that's ideal. I just walked past, I see urine in my patient's bag, or I don't see urine now. What do you think I'm going to do? I've given this fluid. I should see urine. There's no urine.
Stop it.
Check the head of the bed.
Check
If it's not already in the knee.
Check the key, check the
Okay, I'm going to check the catheter to make sure that it's working. Make sure it's not kinked off somewhere or laying on the bed with them. What'd you say? Yeah, I might want to ask my tech, hey, I just went past Mr. So-and-so's room. Did you empty my Foley by any chance? Oh, yeah, I emptied it and I'm going to go document it. Okay, we're good. If they say no, I haven't emptied it for the last 4 hours, do you have a problem?
Yes.
Yeah. What do you need to go do?
Check whether scanner.
Check the lungs.
I might want to go listen to some lung sounds. Because if I'm not excreting all this fluid in my urine, it's backing up into my lungs. That's the problem with hypertonic fluids, is if the kidneys aren't functioning properly, it's going to back up and you're going to put the patient in pulmonary edema. Declamycin, I just put it on there. You don't have to know anything about it except that it is an antibiotic and it is used to treat SIADH. They do not know how it works. It's an unlabeled use for it, but it's mentioned in your book, so I just wanted to include it up there. But it's an antibiotic, but it works, so they use it. Here's our surgery, a hypophysectomy. They go in through the patient's nose, or they can do the surgery by taking this or flopping it back and going in right up here, underneath your, like underneath the lip, okay? And what they do is they go in here to the pituitary gland and either remove the tumor or whatever's causing the problem, okay? So, seeing that picture, what kind of things do you think you need to know to take care of this patient and do patient teaching?
Neurocheck.
Okay, neurochecks, because I was digging around in your brain. I might have messed something up. What else? What position would I put him in? Raise the head of the bed a little bit, just because I want no drainage issues from, my blood flow there. Or if I have any drainage issues from, the surgery site itself. What would drain out of there if I have a problem? Cerebral spinal fluids. What's my patient going to complain of?
Headache.
Headache. Now, is this patient going to complain of a headache anyway?
Yes.
Yeah, they're going to have a headache.
Worsening headache.
A worsening headache and a headache that's severe when you raise the head of the bed. So in that particular case, your patient's going to be flat until the headache, the leak is resolved. What else do I need to think about?
Infection.
What'd you say?
Bleeding or aspiration.
Okay, bleeding or aspiration. So if I have a patient who's all of a sudden swallowing a lot, I might want to check on that because they may be bleeding and it's going down the back of their throat. Usually they have some packing in their nose. Do you think that's comfortable?
No.
Do you think we want them messing with it? So you're going to tell them pre-op, you're going to come with packing in your nose and it's going to stay there until the doctor removes it. Because you're going to feel full. They're going to feel like they can't breathe. And it's weird. They can breathe right through the packing. I don't know what the stuff's made of, but they'll be sound asleep breathing through their nose. But then when they wake up, they'll say, I can't breathe. I can't breathe through my nose. Okay. I mean, I just saw you doing it for 30 minutes, but okay. Just breathe through your mouth. Everything's good. What else do you think I need to think about? What if they go in right here through the gum? Anything I need to teach them? Dental care. Do I want them vigorously brushing their teeth? No, I don't want them anywhere near that area with a toothbrush until those sutures heal up. So they can rinse and spit with warm salt water, but no brushing the area right here above the upper lip where the incision would be. What about blowing my nose? No. First of all, you have packing up there. It ain't gonna be good to blow your nose. And I don't want you doing anything forceful. So when you cough or sneeze, how are you going to do it?
Mouth open.
My mouth open. We talked about intracranial pressure just a little bit. What is a couple things that they need to not do that would increase intracranial pressure?
Don't pick up your 20-pound grandkid.
Yeah, don't pick up your grandkids. Don't bend over to tie your own shoes or work in your garden, things like that. Because every time your head is down lower than the level of your heart, your pressure in your head increases. And so I don't want that to happen. What about infection? You think this is a risk for infection?
Yeah.
So they're probably going to be on some antibiotic for a period of time because one of the core measures is that you receive an antibiotic within 1 hour of the incision and then you receive at least 2 doses after the surgery. So we're going through a very unsterile place into your brain. So risk of infection is a high risk of infection there. Incentive spirometer, yes or no?
Yes.
Okay, I can use the incentive spirometer, but I don't want you to do the coughing part of it. So you can breathe in real deep, breathe out, but don't do the coughing part. If for some reason they have to remove the entire pituitary, what's your patient going to need for the rest of their life?
Hormone
Replacement therapy. You think you can take care of this person? Because we're going to talk about this surgery again with the adrenal glands. Because it's if your problem stems from your pituitary, it'll cause adrenal problems. SIADH, if it's left untreated, causes severe neurological problems. So that's what your biggest complication is. And it can lead to increased ICP, which can put your patient in a coma and it can kill them. So you need to early on recognize this and treat it, okay? Because this is your complication. And really, you're going to treat that in the ICU. Hopefully you didn't get that far if they came to you with this problem. They're going to treat it the same way with diuretics and 3% normal saline. Okay, diabetes insipidus is the exact opposite. I don't have enough antidiuretic hormone, so what is my urine going to look like?
diluted.
Clear. It's going to be very, very clear, almost to the point of looking like water. How much per day can my patient go?
24 to 20.
Up to 20 liters per day. They can put out urine. Can I keep up with that? Drinking wise? No. No, I can barely get 2 liters in. My sodium's going to be low because I'm just excreting it in my urine. I'm sorry. My sodium's going to be high. I need to switch that. It's not going to be high like abnormally high, but it's going to be high. I'll fix that before I'll fix it in your one. Oh, I said it backwards. Okay, sorry. It's high. Sodium's high. Urine specific gravity is going to be low. I'm so tired, y'all. Level 2's killing me. Yes. But the problem is, I'll tell you what my problem is. They've pulled all the level 4 faculty to work in level 1, so there's no one to help us with anything. So we're tired. Anyway, so excuse me if I stumble. So I have a high sodium, but it's not unusually high, it's just concentrated a little bit, okay? Instead of being dilutional. Can you see how my problem, the brain injury, is the same? So if my patient has a head injury and they have increased intracranial pressure, this could go either way. I could have SIADH or I can have diabetes insipidus. My other causes are a little bit different. It can happen with problems from the kidneys. The kidneys just aren't receptive to the antidiuretic hormone anymore, so it just doesn't work. And this does occur during pregnancy. But the head injury, can you see how this ties right back into our cognitive patient? So those are your causes. I'm not going to ask you questions about that. You know that already. So, what?
No, I like it.
I'm not going to ask you questions about that. So your patient is losing a lot of water. What are my signs and symptoms going to be?
Dehydrated.
Dehydrated. They're going to be super dehydrated. So if I'm doing the assessment and I decide that you're super dehydrated, what are you looking at?
Skin
Skin
turgor.
turgor. What's it going to look like? Right. When I go like this on my patient's skin, it's going to stay just like that whenever I let go of it. What else? Hypotension, tachycardia.
They're gonna have weak pulses.
Okay, dry mucous membrane, weak pulses.
Weak what?
Weak pulses. So, did you ever see somebody who had the flu and they were dehydrated? What do their eyes look like? Kind of sunk in. They look sick. Okay? So your patient's going to look sick, especially the more this progresses. Hypotension, you said. What about my LOC?
Decrease.
It's going to be decreased because either way that my sodium goes, up or down, I can have neuro changes. So that's going to be my problem there. The other thing is sodium works with the muscles. And what's my patient going to be like in their gait? They're going to have ataxia. They're going to have an unsteady gait and the inability to make their muscles do what they want their muscles to do. Okay? What do you think I need to do to take care of this person?
Fall risk for sure.
Fall risk for sure, because they might have a decreased LOC, but they're up and down to the bathroom 150 times a day. And you've been in the hospital rooms, there's junk everywhere. What'd you say?
Bedside commode.
Bedside commode, yes, that's the perfect thing. What'd you say? Okay, don't stop the fluids for more than 4 hours. So if my patient's going to surgery, you can't just say, don't eat or drink anything for 8 hours. They have to be admitted to the hospital and have IV fluids. Because 4 hours is the maximum you want them to go without. I want to increase their fluid intake. Like I said, it's hard to keep up with 20 liters out. So a lot of times if they're not taking the medication, they're going to get dehydrated really fast. Are there any kind of foods that promote diuresis that I might want them to avoid? Watermelon, caffeine, cucumbers. There's a whole list of them that promote diuresis. So you just want them to not eat foods that promote. Caffeine's the big one. Watermelon's the other big one. Let's see. This is our new drug. Well, here's how we're going to treat them. Fluid replacement. Oral, if they're on medication and it's controlled, oral's okay. IV, if they're out of control and in the hospital. We're going to give them some antidiuretic hormone, which is called desmopressin, which is a synthetic form of vasopressin. Okay? So all it is your body's not making vasopressin, so I'm giving you the synthetic form of it to treat this. This is the drug they use for kids who wet the bed. And they do it as a nasal spray. One spray before you go to bed. It gives you that little boost of the ADH, and it keeps you from wetting the bed at night. But you can give this medication as a pill or as a nasal spray if it's just a maintenance thing. And if it's severe, you can also give this medication IV or IM in the hospital. Here's the thing. this medication has to be taken every day on time when the dose is due. And it's usually given every 8 hours. We had a patient at Keesler who had a traumatic brain injury and years ago, but he had diabetes insipidus and he was on DDAVP. Well, Keesler, being Keesler, didn't have that medication, and his wife was asked to bring it in so we could give him his own. She brought it in, but nobody followed up with that, and he missed 2 days worth of his medication, so 6 doses, and he ended up in the ICU with severe dehydration. So it's a medication that has to be taken on time, every time. The patients who take it know, and they will be persistent about making sure they get it. Somehow he got lost in the shuffle, and the nurse didn't think it was important, so she didn't follow up on it. So if they use the nasal spray, what do you think you need to think about the inside of the client's nose? Well, they might have dryness in their nose, but it will make them have ulcers. So you just need to they'll get little ulcerations in the mucous membranes of their nose, just as a sensitivity to it. So they need to be aware that if your nose gets sore, you need to let somebody know. The other thing is they'll have constant sniffles. You know, they're just constantly sniffing, and it's just from the medication. If they have chest pain, that's important. They need to let the doctor know that they have chest pain or chest tightness. So if I'm saying that it affects some people's breathing and their cardiac function, you need to use it with caution in clients who have asthma, clients who have heart disease. Vasopressin works on your kidneys. It makes the kidneys activate and hold onto the water or excrete the water. So if my patient has kidney function problems, is it going to be effective? So they have to do a lot of drug testing, lab testing to make sure I've got good kidney function and follow-up care with this drug. Let me make sure that I didn't leave anything off here that's important. On the clock. Oh, what about this? What about a migraine patient? Do you think this medication as a nasal spray could affect a migraine patient? Yeah, because all of a sudden I have the vasospasm, and isn't that the trigger for all of our migraines? Yeah. The vasospasm, then the relaxation with the blood flow is what causes the migraine. So you got to use it cautiously with them. It also interacts with medications. NSAIDs in particular. So my little guy who has diabetes insipidus, and he's been on Celebrex or Motrin or something, I need to be cautious with that because both of those work on the kidneys, and I can cause some kidney problems if they're taking both those medications. What'd you say?
Nothing.
Okay.
She was asking me what you said.
Oh, NSAIDs. So how does it work? It's vasopressin. What do I need to know to give it? Is there any patient teaching I need to know? That's what you need to know about the drug. Can you see how if I don't treat diabetes insipidus, I'm going to have a complete cardiovascular collapse? Because I have no circulating volume to pump anywhere. And so this is fatal if it's not treated. That's why in your head injury patients, it's so important to be monitoring their eyes and O's. You think you're just looking at urine and how much they take in, but it really gives some valuable information if something changes all of a sudden when you're doing eyes and O's on those patients. So that is we're going to talk more about this when we talk in cognition in level 4 about our complications here. All right, we talked about him the other day, so we don't care about him today. I know, and I'm flying, and I'm sorry, but, we have to take lots of time when Ms. Robichaudi was in here to interact.
But you said that that slide is all we need to know about that.
Yes, you need to know.
Excessive growth.
Well, you need to know that the excessive growth occurs after the growth plates are sealed. So it's in an adult client, an insidious onset, so it happens over a long period of time, and then you need to know what kind of symptoms your patient's going to have. Okay? The medications in the book, you don't need to know those. Okay, Cushing's disease and Addison's disease. You know about Cushing's because everybody's seen a Cushing's patient. right?
Eh.
Well, think about it. How many people have you taken care of that have been on prednisone for 100 years? Because they can't breathe. And so they have the big body and the little tiny skinny legs and arms. You've seen them. You might not have recognized them as Cushing's patients, but usually it occurs from an external source, which would be a use of steroids over a prolonged period of time. Okay? So you've seen them in the hospital. Here's what we're going to talk about. We're going to talk about aldosterone. What's aldosterone do? What's aldosterone do? Okay,
It's your like reproductive.
it regulates the blood pressure. But what did you say about potassium? Does it hold potassium or get rid of potassium? It gets rid of potassium. So what is it holding? Okay, it's holding sodium and water to control your blood pressure and excreting potassium in the urine. Okay, cortisol is known as your stress hormone. When you wake up in the morning, your cortisol levels are at the highest they're going to be all day long. So when you wake up and you're already stressed, you're just screwed. So they're at the highest in the morning. After you've had a terrible, stressful day at school or clinical or work or whatever, they're at their lowest. So when you go home, you're all stressed out, you have no stress hormone, what's the first thing you usually do?
Drink wine.
Okay, drink wine. Eat. Don't people eat when they're stressed out? Yes, people tend to munch when they're stressed out about stuff. When you're all stressed out and you're overwhelmed, do you feel like going outside and working out? Or to the gym? You do?
First thing I want to do is go somewhere and
That's why she's so skinny and eats all the time. But can you see how if I have the most in the morning, by the end of the day when my day's been stressful, I'm just done. Okay? So we're going to talk about cortisol. We ain't talking about the sex hormones. Those have to do with, testosterone and estrogen and all that. You talked about that in A&P. This is not maternal child, thank God. So that's what we're going to talk about. Here's what our labs look like in Cushing's disease. I have too much cortisol. Okay? So my cycle is, my negative feedback cycle is broken. So my cortisol levels are high all the time. My sodium levels are high. So what do you think my patient's doing water-wise?
They're retaining it.
They're retaining water. The biggest complications with Cushing's disease is fluid overload. This is vascular fluid overload or peripheral fluid overload? Okay, vascular, but it gets so bad that this patient's going to have peripheral edema. Okay, my potassium is low. So what kind of cardiac issues do you think I might have? I might have some dysrhythmias because of my potassium level. My glucose level is going to be high because I'm all stressed out. When you're stressed, your glucose level goes up. So those are my labs for Cushing's disease. Here's your diagnostic test, which I don't think you guys knew at all. Where is Cushing's disease? I don't know where it's at up here. Over here? I'm going to look in. You have a test up there. You have the ACTH stimulation test. That's the test for Addison's. This is the test for Cushing's. A 24-hour urine-free cortisol. What do I need to know to do a 24-hour urine?
Discard the first urine.
Discard the first urine. So I peed at 3:02. That's what time I'm starting my 24-hour urine, but I'm throwing that urine away. Okay? So what else do I need to know?
Sign on the
If
door.
you mess up, like if you accidentally don't hold, keep that urine, you have to restart.
Okay, so if I miss it, or if I flush it, or if a family member flushes it, I got to start all over. I can't just say, oh, I missed 300 cc's, we're still good to go. Or if you put toilet paper in the hat that you're collecting it in, you have to throw it away. Okay, she just said it sucks, and it really does for the patient and for the nurse. So, what do you need to do?
Put a sign on the door.
Yes, you need to communicate with each other. You need to communicate with your patient and the family. You need to communicate with the nurse that's taking your place, because there's nothing like going in at 10 o'clock and having a potty full of urine and finally seeing a sign that says 24-hour urine in progress. Oh, great, because that piece is sitting there for how long? So you communicate that in your report. What about with your tech? Yeah, they need to know because they need to know what to do with it. What do I do with the urine once I've collected it?
Fridge.
I have to keep it cold. Where do I keep it? Okay, I can keep it in the fridge,
Or the above.
but do all units have a fridge specifically for labs?
No.
No, they don't. And don't put it in the break room fridge. Nobody appreciates that. Or the medication fridge. They don't like that either. So what am I going to do with it? I'm going to put it on a bucket of ice. So I put it on ice at 7 o'clock when I got here because I'm good. I'm collecting my 24-hour urine. Is there still ice in my bucket at 2 o'clock in the afternoon? No. So now I'm keeping up with ice and urine to make sure that it stays cold. If I'm collecting it in a Foley bag, if my patient has a Foley catheter, can I just put the Foley catheter in the bucket of ice right there at the bedside
Yes.
and keep it cold?
Yes.
What else do I need to know about a 24-hour urine? Anything else?
No menstrual blood.
Yeah, they don't like any menstrual blood in it. It's kind of hard sometimes, depending on, what's going on with your patient. No poop in it either, okay? So if your patient has the hat and they collect urine, but there's stool in it, can't keep it. It's got to go. So real particular on that. This one is a midnight plasma and salivary cortisol. And what they do is at midnight, they draw a serum cortisol level and they swab the inside of your mouth. And they're looking for, they should be the same or pretty much the same level. If there's a difference in the level, they can use that as a diagnostic measure. The low-dose dexamethasone test is a test that's pretty time sensitive. You draw some blood or urine, they give the IV dexamethasone, and then in incremental time, I think it's an hour and 2 hours, you draw blood again to see what the changes is in the cortisol level. The thing about this is, I don't want you in the book to memorize, I'm going to give 0.8 of this and 7.4 of that. I don't want you to memorize that. I want you to understand that if I don't do this in a time-sensitive manner, I'm going to get skewed results, and we're going to have to start all over again. And nobody's going to be your friend. Administration in particular, they will hate you.
Do you want us to know the specific times?
No,
Okay.
no.
Just know that it.
Just know that that's the diagnostic test, and it is time-specific,
Okay.
time-sensitive. There's only like this much about it in your book,
Okay.
Caused by an external source. We talked about that. And that is chronic use of glucocorticoids. So your patients who have autoimmune diseases and your patients who have COPD, your patients who have like rheumatoid arthritis, these are the patients you're going to see the Cushing's disease, which is the syndrome caused by an external source. If the problem comes from the pituitary gland not secreting enough ACTH, or the adrenal gland not... Are you breaking stuff?
Yeah.
That's why we can't have nice things.
I'll be back too far.
If it comes from the adrenal gland or the pituitary gland, it's an internal source and it's Cushing's disease. That's the difference. They just refer to it in your book as Cushing's, but I just want you to know when you take your NCLEX, Cushing's disease is from your own body not working. Cushing's syndrome is from an external source. Just so you know the difference between the two terms.
Are they both chronic? Like you can't get rid of it once you have it?
Well, if I can get myself off of the steroids somehow, the symptoms will get better and go away.
Oh, okay.
You see what I'm saying?
Yeah, yeah.
But as long as I continue to take the steroid, which if I have COPD and I need it to breathe,
Then,
I'm
yeah.
probably never going to get off of it. What's your question?
It was on the PowerPoint.
Oh, okay.
Yeah.
Okay. So, what's this patient look like? What does their skin look like? You ever seen somebody who had on the steroids all the time? Real thin. They have all those little bright red bruises all over there. Ecchymosis everywhere. When I take the tape off to take their IV out, I have to be really careful because I can just tear their skin off right with it, okay? Because they have that thin, fragile skin. They've got the truncal obesity. They got the little skinny arms and legs.
And from here to here, they're like weebles. Okay? What? They are. Moon face, the round face. Ecchymosis. What are striae? Stretch marks. Because all of a sudden they've gained all this weight real quick. They'll have stretch marks, particularly on their abdomen, the back of their arms, their thighs. We call them striae because that sounds better than stretch marks. High sugar and high sodium. Okay, those are the labs. What is excessive facial hair? What is that called? Hirsutism. Yes. So when your hormones are out of whack, you'll see older ladies that have the fancy mustache and facial hair. It's because their hormones are out of whack. So this is one of the hormones that causes that. The dorsocervical fat, or the buffalo hump, is, you'll see them, they actually have brown fat right here on their backs that you can see a hump right there. And then depression. Now, people who have this internally do have depression because of the body image changes. But think about a person who all of a sudden has to take prednisone for a 6-month period, and they went from their little tiny 122 pounds to now they're up in the 150s. Proportionally, they're not the same. High rate of depression among Cushing's patients because of the body image changes. Here's a... How did he get there? I didn't want him there. I have a picture of a Cushing's person in here somewhere. Let me see if I can find it real quick. Maybe I deleted them. I don't know. I might have deleted them. I'll put it back in though and put them on there for you. What do you? Stupid thing. Hold on a second. Let me get you back up here. So what do you think I need to do to take care of this person with Cushing's? Tell me what I need to do. What do I need to think about? Emotional support. Diet. What kind of diet? Okay, low calorie. Okay. Which do I want? Potassium or sodium?
So you want to put potassium sparing?
Okay. I want a potassium sparing diuretic because my patient's getting rid of potassium. What do I want them to use on their food if they want? I can't eat that with no salt on it. They can use a salt substitute because the salt substitute is truly potassium. Okay? It's potassium chloride. Mrs. Dash adds some flavor to it. Things like that. What about fluid restriction? If I told you fluid was his biggest problem, what about fluid restriction? He needs to be on a fluid restriction and weighed to make sure that he's not gaining weight. If they're on steroids, they can't just stop the steroid on their own. They have to taper it with the doctor's schedule for tapering. What about their skin?
It'll be shiny.
Well, I need to monitor for skin breakdown because if their skin's super fragile and they're not as mobile as they used to be, or they're clumsy or fall, they're going to have some skin problems. Infections. Their cortisol level is super high, so their immune system is super low. So you got to think about those things. Avoid crowds. Wash your hands. What am I going to do as the nurse to protect my patient?
Wash your hands.
I'm going to wash my hands.
Don't be sick while you're taking care of them.
Okay, if I'm sick, I really don't want to be taking care of them. But when I come to you and say, I don't feel good today, will you trade me for that person in 37 when they've been here, that patient on the light 500 times? What's she going to say? No. Nope.
So wear
I'll
a
keep
mask.
the ones I got. So you're going to wear a mask. If you don't feel good, you're going to wear a mask to protect them from whatever you're carrying around. Provide emotional support. Let's see. Monitor their glucose because their glucose is high. So just because I'm checking your blood sugar, I go in and I check her blood sugar and it's 214 and I say, I got to give you some PR and insulin because your blood sugar is so high. And what's she going to say to me? I'm not a diabetic. I don't take insulin. So I need to be the one to teach her this is a temporary thing because of your cortisol levels. Your glucose is high. And so we have to treat your hyperglycemia, okay? Because a lot of them, that's the first thing they're going to say. I don't take insulin, I'm not a diabetic. So it's up to you to tell them why they're getting that insulin at the time.
Can they become a permanent diabetic from this process?
One of our complications is metabolic syndrome, and yes, it can lead to type 2 diabetes. Yeah, I have a slide with the complications. So potassium replacement. If I'm giving it orally, is there anything that I need to know?
Heart monitor.
I'm just giving it orally. I take potassium every day. I don't wear a heart monitor.
Oh, okay.
I took it this morning on my way here.
Nice.
They're big.
Yes, they're huge. And as soon as they hit any kind of wet surface, they start to dissolve. So I can break it in half if they're too big for my patient to take. I can dissolve it in water. It's kind of salty tasting. But they are big, but they start dissolving the minute water hits them. So the minute they put them in their mouth. They do cause some GI upset sometimes. So if my patient can take it with a little bit of food, it'll prevent the GI upset with the potassium. What if I'm giving the liquid potassium orally?
You gotta put it in something.
I got to put it in something. It burns like fire going down because it's that little cup, the 30 cc's is very concentrated. And I promise you that you're only going to convince your patient to take it that way one time. And then put it in some kind of juice so that it kind of disguises it a little bit. What kind of juice would actually be a good juice to choose?
Cranberry or orange juice or apple.
Orange juice would be great because it has the potassium in it also, and it really has a flavor that'll cover up the taste of it because it is salty tasting when they dissolve. I'm going to use insulin PRN, and we kind of already talked about that because I want to keep their blood sugar in check even though this problem is coming from either an outside source or temporary thing.
What was the second thing you said about the oral potassium? They start dissolving as soon as they get wet. And
As soon as
you said something else.
you can break them in half.
Okay.
You can break them in half. But, I mean, your patient's going to look at it the first time and say, I can't swallow that, it's too big, because they are huge. Here's our surgeries that we need to think about. The hypophysectomy, you have a question?
Said, don't put them on heart monitor.
If they're on IV. Oh, let's talk about IV potassium. She said oral potassium. She's going to put on a heart monitor. I take oral potassium 2 times a day. I don't wear a heart monitor. So they don't need to be on that if they're just taking oral potassium. But if you're giving it IV, they do need to be on a heart monitor.
Never IV push it.
Never IV push it. It's always in a bag, and it actually comes pre-mixed now. We used to mix it ourselves. That was disastrous. It comes pre-mixed now, where it comes 10 milliequivalents in a 100 cc bag, or 20 milliequivalents in a 100 cc bag. What's the difference between those two besides 10 milliequivalents? I mean, I know that. What's the difference in the way I can give them?
The rate?
Okay, if it's 10 milliequivalents in a 100 cc bag, I can give it through a peripheral IV. It's safe to do that. If it's 20 milliequivalents, because they need it a little bit faster, I can only give that through a large vessel IV, like a PICC line, or a central line, or a portacap. So if it's over 10, it has to be a better IV than the ones we can start as just regular old RNs. Yeah.
Can you put it in a larger saline bag? Like
I-
I gave 20 MEQs yesterday in 1,000 milliliters.
Yes, but that was not for potassium replacement.
Oh,
That was just for if it's in a 1,000 cc bag, think about that. If I'm replacing potassium, but I give you 10 milliequivalents in a 1,000 cc bag, am I making any headway? No, I'm just maintaining. So I can do 10 to 20 in a 1,000 cc bag over 8 hours or whatever. But if I'm giving that concentrated dose of 10 to 20 in the 100 cc's, that's where my IV makes a difference. When your patient tells you this is burning like fire, they are not lying. Okay? So you can turn down the rate a little bit, or, you all know because you're in level 3 now, and you know what I'm talking about. Level 2, they look at you like, I don't even know what you're saying. If you have your primary IV fluids, and you're running a secondary bag of your potassium, you know how we hook it above the port? Mm-hmm. Which one's running? Just this one. But if I use long tubing and I run them both on their own pumps, then they're still getting the full benefit of my concentrated dose, but they're also getting their IV fluids, and it doesn't burn near as bad when it's going through the IV. So they're not lying when they say it burns. It does burn like fire. No, it can go in the same IV, but instead of you're running on your pump, you're running A and B together at the same time. Because if I just run A with a secondary, they're only getting that little concentrated bag and it burns. You see what I'm saying?
Would that be in the order, or we can do that ourselves?
You can do that yourselves.
Okay.
You can do that yourselves. Lots of nurses just turn the rate down, but if the purpose is to give 10 milliequivalents, you're going to give usually 4 bags, each one over an hour, and now I've reduced the rate to 20 cc's an hour because my patient says it's burning.
But it's gonna be pushed back.
It's going to take
Yeah.
24 hours to get those 40 milliequivalents of potassium in. It doesn't make any sense.
Okay.
Because the purpose is to get it in there and correct my potassium problem. Okay? You guys take a break, come back at the top of the hour, and we'll talk about the adrenalectomy.
I know.